falling, they pitch on their head. Their uniforms are heavy and wet. The shoes full of slurry. There's no time to worry. There's no time to brood over it. Troops moving forward, spring to their arms. They're ready now to fire again.
Is there anything you guys need help with today? Other than
Afraid of being bugged,
since we've been doing
afraid
this
of
together
running
for so long.
circles again. When I'm on my road again, on the road I was before. When I'm on my road again, on the road I was before. After many adventures in so many regions, they seem to be lost this time. There is no orientation, there's just a frustration, there's just a despair. But what to do to stay alive?
Good morning.
Good morning.
Good morning. Good morning.
I am not the normal person that would be standing before you giving this type of introduction. But my name is Valerie Taylor. I am a registered nurse, and I work with the VA in San Antonio. I came down with the UT Health Science Center to help present this program, and we have a lot of wonderful speakers that are on the agenda today. Joe Zapaga, who would be normally the person that is doing this, if any of you know him, extremely energetic and everything, but he is not well. So we left him at the hotel sick with pink eye. So just lift up a prayer for Joe this morning because he is not doing well. So I'm going to try to do the best I can just to kind of fill in some housekeeping items, and I think you will really enjoy today. The first thing I just want to draw your attention to is there is a participant profile that everyone should have received. If you didn't receive this profile, let me know. But this also, you probably think it's pertaining to CEs. I think that's how I explained it, and that's what I thought specifically. But it is a profile, and let me see what Joe said. He says, the participant profile is a voluntary demographic profile which helps us secure funding for future events. So how many of you like the word free? F-R-E-E? Okay, so we want to keep those happening. So that's why you fill out as much as you can, and so that we can continue doing that. And also, this, let's see what... They can give this, okay, you can give it to me at any time. I'll probably pick it up at the end of the session, or if you have it finished at a break, I can pick that up too. There is a statement of attendance. Those seeking CEUs turn in at the end of the conference, fill it out completely. So I think that is this form. It's stapled, and it is a statement of attendance, and inside there are, let's see, okay, for some of you that are healthcare workers, it says LPC and others, that's you, okay, and you will get 6.25 credits on that. So, and at the end, what Joe does normally is he will send you, make sure you've got an email address, because he will email you information for you to fill out, and then he will send your certificate for all of us electronically, okay? So those of you that know him, that's exactly what he does. Oh, that's what he says. I will email everyone an evaluation link. Upon completion, then I will send a certificate. And that is pretty much it. We do have a number of speakers. They will introduce themselves. So you will see me floating around. If there's anything that I can do to help you, please ask. There's also Esther Fuentes, who is out. Anyone on that front table that you saw in the beginning of the session, or as you were coming in for registration, please let us know if we can do anything to make your the conference a lot more rewarding for you. Okay? Thank you. And our first speaker is coming up.
Have fun.
Good morning.
Morning.
Good morning.
Is this a good volume? Everybody can hear me? Okay? Too loud or? Okay. So my name is Tracey Cawthorn. I am from the Health Science Center in San Antonio. I'm a first-year faculty member. I do, I did my medical school, my residency, and my fellowship training in geriatric psychiatry, so that's pretty much what I do. I have an outpatient clinic at the medical school, and I also do consults at the University Hospital primarily. Today I will talk about some disparity in the healthcare of dementia in Texas. So I wanted to start with kind of an introduction of the case. Okay, so 71-year-old male brought into the office with his family who's been having some memory problems for maybe the last 8 or 9 years or so. Just kind of declining, getting worse. Family's kind of covering up for him, and it's getting to the point where he's needing more and more help with things like dressing himself, bathing himself, doing bizarre things like putting the keys in the freezer, not being able to manage his medications, his finances. They have to stop him from driving. He can't get himself to and from medical appointments, things like that. So now the problem has become that he's becoming more and more delusional and paranoid. He's more and more verbally aggressive towards the family when they try to redirect him. So if he tries to wander outside the house and they try to stop him, he's a little more, not really physically combative, but we'll let him know that he doesn't agree in not so nice terms. Let's say that. He's a little more paranoid about the family. People are stealing from him, doesn't trust the family, and things like that. So this is pretty typical of a case that might walk into my office. It's actually one of my first cases that I had. Okay, so Alzheimer's. So 35.6 million, why do you think that, or why is that number important? All right. Anybody take a guess? So the number of people who actually have Alzheimer's disease in the United States, so that's only the people who have actually been diagnosed. Like I told you, this gentleman's been kind of declining over the last 8 or 9 years. That's only the people that we have on the radar, right? So just to give you an idea, because I'm not the smartest person in the world, so I hear 35.6 million and you think, I mean, how many is that, like a football field? I don't know. That's kind of fun. So these are kind of population of countries, and you can see that's more people than like a lot of countries, right? So that's a lot of people that we have to take care of. Okay, so why is dementia important? So that's a lot of people, for one, 35 million people. And this number is expected to double by 2030, more than triple by 2050. As I told you before, between 2 and 10% of those cases actually start before the age of 65. The gentleman that I mentioned to you before was 71 when he walked in the door. And by the time you get the history from the family, that's actually started probably 10 years before then. A lot of times you'll have family members that will cover, and I'm sure you've seen that, where they finally bring the family member in, and you're like, how long has this been going on? Oh, he was fine 6 months ago. You're like, really? Fine? What does that mean to you? It's fine to me means he was fine, but so you have to question that a little bit more. Okay. So another reason it's important is dementia is one of the major causes of disability in the later life. 12% of the years that actually live with disability are actually due to non-communicable diseases. So not the infections, not the pneumonias, not the #1 killer, heart diseases. It's actually the leading cause of dependency. So the need for home care providers, the need for people to help with transportation, finances, medications, all of those things. So all of that help costs a lot of money. Actually, $604 billion. So that was the worldwide cost, actually. I put U.S. because that's U.S. currency, right? So, but that's a lot of money, $604 billion for just the care alone. And you can see that the majority of that is coming from the indirect care. It's not the actual pneumonias, hospital stay, broken hips, things like that. It's the informal dependency care. So, U.S. statistics, 5.2 million Americans of all ages have Alzheimer's disease. And like I mentioned before, quite a few of them are actually starting under the age of 65 with the beginning symptoms. And between 2000 and 2010, the deaths that were attributed to Alzheimer's disease actually increased about 68%, while the number of deaths that were attributed to the #1 killer, which is actually heart disease, decreased by 16%. So the age 65 and older survive an average of 4 to 8 years after a diagnosis of Alzheimer's disease. But some can live as long as 20 years with Alzheimer's disease. So that's a lot more money that you have to spend with the caregiving, and they also get sick, so there's some direct care financially that you have to do as well. Okay, so Texas statistics. Okay. Texas alone, there are about 340,000 people living with Alzheimer's disease, expected to increase to about 470. So if we look at the population of Texas, and this is just kind of a population not broken down by anything, okay? So there's a lot of births in Texas. So by far the majority of people are between 0 and 19 years, right? And so this is the actual and projected. However, you can see that the number of 60 plus is steadily increasing. So I mentioned to you before, or I said before, the numbers of dementia is expected to double and triple in the next, by 2030, 2050. One of the major risk factors of Alzheimer's disease is age. So as people are getting to 75, 80 years old, their chances of developing Alzheimer's disease increases to 55–60%. So usually by the age 80–85%, roughly 45–50% of those people are going to have Alzheimer's disease. Okay, so let's go back to our case. So I mentioned to you that there's a 71-year-old male. He's brought in by his family, and he's got, the problems that we said before, some memory problems. But they're bringing him in now because he's starting to wander, he's got some paranoia, and it's been more difficult to handle him. So what are some goals of treatment? What are the things that we need to do to help this family? Like, what are they looking for? Yes. From your perspective.
Well, I say that they don't want him to get lost if he's wandering, perhaps.
Okay, so we need to focus on, I guess you're saying more of the behavioral disturbance? So safety, right? Medication focused on what exactly? I guess what are we trying to treat? Right, so it's paranoia, which kind of goes along with the safety, right? We don't want there to become any physical aggression, as we all know can happen, right? Okay.
I'd look at what's going on with him medically. There may be some medical, and that goes along with the medications, but, if he's dehydrated or if he's got an infection, that might be causing some of the delusional stuff. It may be more of a
a delirium rather than a dementia type thing. You just don't know. So.
Right, absolutely, absolutely.
I'd like to ask a question more in terms of some of your previous slides. Why is there an anticipation of an increase of numbers like doubling? Why is that anticipated to increase in that way?
People are living longer. We've got advanced technology, more medication. We're taking better care of ourselves. We're getting healthier with the, less people are smoking. We have better, I don't know the numbers off the top of my head, I forgot. But the stroke prevention.
So basically you're saying just because of the increase in population, not necessarily because of the things that attribute to Alzheimer's? Or?
Oh, right, yeah.
But if we're healthier, we're taking better care of ourselves, shouldn't that help us to prevent some of this dementia?
So there's some evidence that exercise and some types of vitamins and other things can contribute or can help to prevent Alzheimer's, but there hasn't been anything that's definitely proven to prevent Alzheimer's disease. So those kind of studies are still ongoing, and so I can't say definitively, that if you exercise 30 minutes a day, your chances of Alzheimer's are less, or, they're always kind of equivocal studies.
We're also having more younger people developing Alzheimer's and dementia.
So generally those can be, usually are more familial cases where you have a genetic type of Alzheimer's disease, or you have a different type of dementia that's developed and it's not necessarily Alzheimer's disease. Good questions. Did you have anything to add? Okay. So absolutely. So our goals of treatment for this gentleman, we want to look at his medical profile to see if there's anything going on, if there's any delirium. We want to check his medications, make sure that's okay. We want to make sure that there's, that there's no mood disturbance going on, any anxiety disturbance that we can treat. Definitely want to help his cognition if we can, right? Behavioral disturbance, definitely, because there could definitely be a safety issue. And then we need to address his daily care and his end-of-life issues. So there's one piece of information that we need to elicit from the patient and his family that I didn't give to you. Any ideas what that could be? A social piece of information. Or environmental, I guess. Yeah, so along those lines, yeah. So I didn't give you his social history. So he's actually born and raised in Mexico. He immigrated when he in his early 20s, not in the early 20s. He's been married once to his lovely, very sweet wife for 40 years. They have 3 adult children, 5 grandchildren. He worked as a laborer, so he doesn't have a lot of education, formal education. And he currently lives with his wife alone. So socially, his caregiver is primarily his wife. He's got the 3 adult children. They are very close. He's got probably the best family you can ask for. They're very successful. The closest daughter lives probably 2 or 3 blocks away from them, but she's a school teacher. She's got a family. So she comes in probably 2 or 3 times a week to make sure things are okay. Does the pill box, checks the pills, make sure that, mom and dad eat. She tries her best to get to their appointments or whatever, but mom doesn't drive either. I'm sorry, the wife doesn't drive either. So it's difficult for her to get there all the time. The other 2 children, one of them does live in San Antonio, but kind of has more of a demanding job. And the other one lives in Austin, so can't come as often, but they're all very much involved in the care. Okay, so he's got very good social support, but I just want to kind of bring that to mind because that kind of, if anything, changes the way that we think about a couple of these things, right? So at least with the daily care, because some people might say, well, we can ask the adult children to step it up a little bit. Or you can have them get another home care provider or somebody like that, right? But I mean, these people are doing the best that they can, and this family really is involved in this gentleman's care. Okay, so hearing for this gentleman, before we even start to discuss the options, you have to talk to the family about how they want to go about things. So there's something called therapeutic non-disclosures. Anybody know what that means? Anybody? So that kind of means that it's more important for the patient not to know what's going on, and we'll just kind of talk to the family and do what we need to do for them. So that happens in some cultures where, primarily I've seen it in Native American cultures, Hispanic culture, Asian culture, and occasionally in the African American culture, where maybe there's an incurable cancer or a progressive dementia or something like that. So we'll get him to his radiation treatments, we'll get him to chemo, just don't tell him that he has cancer. Or, you know, we're not going to do anything, we're just going to do kind of palliative care, but don't tell him that he has cancer. Because it's better for them not to know and just kind of live the rest of their days happy, okay? So before we kind of have that discussion where dad has Alzheimer's disease, this is what we're going to do, we kind of need to know culturally, socially, you know, where that family's coming from, okay? We need to know the views of their views of the medical community. And that can vary by race, ethnicity, religion, and those are going to change the way that they view long-term care. There are some ethnicities that are more in line with long-term care facilities such as assisted living, nursing homes, having home care providers, or where they're just going to kind of pull together as a family and keep that person at home as long as possible. Versus end-of-life care, it's very difficult for some cultures to have that DNR, DNI, advanced directive conversation as opposed to others. So these are things that we need to focus on or think about. Yes,
You know, in that, part of it is extremely important, you know, like your end of life, your advanced directives and all, because if they get to that point and nothing's been done, then the family's really in a quandary.
Right, so initially when I'm first seeing a patient, I try to have these conversations early. A lot of times it's difficult because nobody really wants to hear mom has dementia, and so you try to let that sink in and not, you know, throw too much on them. But it really is important because depending on, you know, how fast the progression is, people don't really understand all the things that need to be in place legally on paper before things happen, and I mean, it does blow up, you know, so yeah, it's very important for you to kind of have that in place while the person, you know, can still participate if you can catch it early. So, anyone else have any questions or comments or anything so far? Okay. So I found this on the Economic Modeling Specialist website, which is just kind of a census website. And this was a percentage of the Hispanics in Texas. So you can see primarily in South Texas is about 80% Hispanic. So 81% of the South Texas population compared to 36% in the state overall. Laredo actually was 95% Hispanic, McAllen 89%, Brownsville 86%, and non-white Hispanics accounted for about 16 or so percent in the Texas population. You know, by 2012, this was a projection back then, Hispanic population was projected to rise to 82% versus 37% as a whole. Again, this was in 2007. So this was looking at the location quotient by race. So again, this is not just kind of the total population, this is kind of more of like a concentration in an area, so to speak. So the concentration of Hispanics in the South Texas region was more than twice as high as the states and more than 5 times higher than the nations. Its pattern is illustrated by a common measure in economic and demographic analysis. So the location quotient is the ratio that can be used to compare the concentration of a given group, again, in a specific location with and you can compare it with state or nation. So you can see compared to South Texas versus the nation, right? So we have a higher concentration. Okay, so this is the location quotient by age. And so you can see as you get older, there's more of the Hispanic population that are older, right? And so these are kind of the demographic that I'm speaking to in South Texas, like the gentleman that is in our case. So it's a rising problem. This slide, we found that from 2002 to 2007, the South Texas region's population increased at about 2.1% annually. Growth in the metropolitan areas in McAllen-Edinburg led the regional growth by increasing about 3.3% annually. And this unfortunately didn't break it down by age, but just to kind of reiterate that kind of this area is growing in population kind of very rapidly. And this kind of broke it down by cities, you know, instead of just kind of South Texas. Okay. So on this slide, it had kind of a busy slide, so I don't know if there's a pointer on here. Okay. This was a slide that I thought looked at a lot of the issues that our gentleman had. So there's a high growth, if you look at the first column, there's a high growth of our 65 plus population in the Hispanic community in South Texas. They're bilingual, they're underrepresented in health professions, which is reversing or changing now. Below average education and income level. And then if you look at the health insurance issues like Medicaid, Medicare, as I mentioned before, there's a lot of money that goes into their health care that's not exactly covered by Medicare, Medicaid. And so a lot of times these people have to come out of pocket for their home care, their medications, and the health information transparency and pay for performance will affect them more than, say, other people that are middle class, upper class, that are able to kind of pay out of pocket for those long-term care, nursing homes, those kind of upper class facilities. So what do we mean by culturally sensitive dementia care? So by no means do we mean put everyone in a box and kind of treat them all the same by ethnicity, but to consider each person as an individual as well as a product of their country, religion, ethnic background, language, and family system. So like I said before we have that conversation with, say, this gentleman's family, we need to know, how much do they want this gentleman to know? How much are they willing to participate in his care? Do we need to have a family meeting? And so forth. To understand the linguistic, economic, and social barriers. So are the families willing to be involved? Are they able to have a home care provider come in? There's a lot of people that don't like to have people come in their houses, and I've seen that more with the kind of the older ladies, you know, like nobody's coming in my house and cleaning my kitchen, and you know, like, so those are kind of the barriers we have there. And then economic, if you want to keep someone in your home or in their home, are they going to be able to afford that out of pocket? What kind of resources do they have, and so forth. Considering alternative to Western philosophy and practice, which is kind of important in some cultures, primarily Asian culture, some African American culture, and Hispanic culture, where they use more vitamins or maybe rituals or something like that. And not to place anyone into a particular ethnic group in the same category when you're doing a treatment plan. So Learning to respect social and cultural differences, considering the family's background experience and determining service and treatment plan again, considering the cultural perceptions of aging, caring for the elderly and memory impairment. Sometimes people can look at memory impairment as normal, and that kind of prevents them from coming in earlier. Like, oh, she's just forgetful, that's normal, she's just, you know, senile, and they kind of don't really realize that something else is going on with them. Understanding that family's culture impacts their choices regarding ethical issues. So, like I said before, unless you understand where that family's coming from socially and ethnically, you can't really have those end-of-life, long-term care conversations with them. And then to remember to consider the faith community. There are some cultures that are very strongly faith-based and will use a lot of their religious kind of rituals, have their pastoral care involved, and those are things that you need to involve in your treatment plan as well. So we as providers and healthcare providers need to value diversity, awareness, and acceptance of these differences, be more self-aware of our own culture and our own preferences and how that impacts our ability to care for other cultures. Be aware of the dynamics of those differences, be conscious of the dynamics inherent when cultures interact, and develop a knowledge of those clients' cultures and be able to adapt our skills to care for each client individually as appropriate.
Question?
Yeah.
You mentioned supplements earlier.
I'm sorry, I can't hear you.
You mentioned supplements earlier or vitamins. Typically, you go to a physician and they don't order vitamins or supplements. So who do you go to get some type of evaluation or recommendation?
Usually those are doctors of osteopathy, like the DOs, or they get them from like their religious person, like a pastor, or I forget what they call it, like the Asian culture.
Curandera.
Like a curandera, or like a, who they call them in the Asian, I can't remember, but they don't come from physicians. What I'm saying is like an alternative to Western healthcare. So like not from the physician.
Homeopath?
Like homeopathic medicine, yeah. So like St. John's wort wouldn't come from your PCP. You know what I
You have
mean?
to do your own research and or find somebody
Yeah.
specialist.
Usually they're not medically, like they're not medical professionals. Yeah. Go ahead.
Would there be concern if they were to use supplemental medications and all, or over-the-counters? Would that maybe raise a red flag on that, or what would they need to consider if they're considering some alternative type medications or over-the-counter things or herbs or whatever for their loved one?
Generally, as long as the physician knows and we can make sure that there's not any interactions with anything else that they're taking, or that, say, if they have a liver disease, that medication isn't more hepatotoxic or damaging to the liver, then usually they're okay. They can take them, and if they feel, you know, comfortable and they're not having any side effects, then it's okay. But it needs to be checked out by, you know, either their specialist or their primary care physician.
Excuse me, can you get closer to the mic?
Oh, I'm sorry.
Here, thank you. Yes? There's a question over there, I'm sorry.
Are there any vitamins or whatever that you would recommend in the treatment of dementia?
None that I can say definitively that have been proven, you know, 100%. I know they're looking at more vitamin E, and what are some others?
B.
Well, actually, if you're thinking about the, like when we order, you know, the full workup for dementia, So we always have to order the levels of vitamin B12 and folic acid. So
Yeah,
actually,
those are low.
if you have an objective documentation that this patient suffers from, either because of underlying medical condition like pernicious anemia or, malnutrition status. So those patients, of course, they benefit from vitamin supplementation of those specific vitamins. So those will be what we call, or tend to call, reversible type of dementia syndromes, due to a general medical condition. So in those cases, so we won't call that particular patient having Alzheimer's disease. So you have to be very careful so that's why you have to do the initial workup and finally diagnosis of exclusion, even though it's a clinical diagnosis.
So if we can find a deficiency, then we would supplement that one. But I thought your question was more, is there something we can take to prevent?
Yes.
Okay, no.
So
But
vitamin
also,
B1.
nonetheless, patients that you kind of correct that variable, and let's say you treat the patients with the vitamin B12 deficiency, they still can get Alzheimer's disease. You see?
Right.
So,
Does vitamin B1 play any part at all in this?
say that again.
Does vitamins help at all?
Thiamine is good for cognition in general,
Right.
but it's for other medical reasons that are related to other types of dementia. So particularly.
Alcoholics always get it.
Exactly.
Right,
There
and
you go.
it improves them
Uh-huh.
tremendously mentally.
Yes, but it helps for cognition. Yes.
But also will prevent Alzheimer's disease.
Not at all. Not from prevention.
Right.
Exactly.
Other questions? Sorry. All right, so by far am I not the expert of Hispanic and Latino culture. This is some stuff that I pulled up off some papers that I was reading while I was doing some research on this topic. So there's widely diverse from Spain, Mexico, Puerto Rico, Cuba, Central and South America. But by far, Mexican Americans constitute the largest group of with the largest kinship ties to southwest part of the United States, therefore largest minority group in Texas. They're actually the second largest minority group, 9%, 1.5 million elders, which is projected to be about 13 million by 2050. So a little bit about that culture. The family unit is the center of most activity and support. Most of the care for these elders are provided by extended families. And some cultures will kind of include friends as part of their family unit. Others will not. I read that Puerto Ricans are more likely to include non-blood kin in their family, especially when they're kind of providing some of the care for their elders. But again, less likely to use kind of more of the long-term care facilities and those outside resources. Majority practice Catholicism, although some members are Protestant denomination, and they will seek strong emotional and spiritual support and solace in religious beliefs to cope with stress, and also to help deal with any medical issues that they're having. Doctors typically viewed as authority figures. They receive a lot of their healthcare information from Spanish media. Important not to confuse a person's country of origin. And I thought this was odd, but I found this in several papers that they lack transportation. I didn't really understand why that was in there, but that was in like 3 or 4 different papers. But anyway. And something else that they said that when you're a medical provider that they're more open to physical contact than other cultures were. So I guess like handshaking, hugging, something like that. So that was interesting.
I have a comment to make on this often lacks transportation, and it
Yes,
kind of
ma'am.
relates to I'm getting the impression that most of the people that you've worked with have very good support from their family. And that's not what I see in my practice, actually. And this often lack transportation has to do with their children either having jobs that cannot leave to come take them to the doctor, or just don't wish to come to take them to the doctor. So that's kind of interesting diversion there.
And so they're
that I'm seeing.
typically unfunded then, or?
Yes and no.
See, because we have something called
Economics
pediatrics.
doesn't seem to make that much of an impact on this profile that we see.
Because we have pediatrics is that Medicare? Comes to pick them up and take them to their medical appointments or something like that, but I guess that doesn't.
And a lot of the adult care centers, daycare centers, take them to their appointments, but if it weren't for them, they wouldn't get to their
Right.
appointments.
Yeah.
Because I have seen that as well. And sometimes when we look for places to place these people, we're looking a lot at how will healthcare be continued, because there isn't usually no one that can help. So this is kind of an interesting diversion that I'm seeing.
Just as information, a high number live in colonias. For example, Hidalgo County is the largest number of colonias in the state of Texas. There is a very big lack of public transportation into those areas. And so even transportation to get to basic needs like food or access to a doctor, that's where you have a great deal of problems, and that's why it's usually listed as a lack of transportation.
Okay. San Antonio. So help-seeking methods, particularly early stages of cognition impairment, like I said before, is usually viewed as normal aging. But sometimes it can be looked at as a punishment for having past bad sins or bad blood, mental illness. They may not seek out services to avoid shaming the family, or maybe attributed to nervios or mal de ojo. Yes, ma'am.
What would the early stages of cognitive impairment consist of? Like, what would we be looking at?
That's difficult to say because it's kind of individualized, but it's kind of, so everybody has their senior moments, right? But it's kind of, you laugh like you had one today. Like, but, I mean, it's kind of where it's becoming more frequent, maybe forgetting names, but it's more specific to that person. So like me, if I were to put my coffee cup on top of the car and drive off, people probably wouldn't think anything of it because I do that probably twice a week, right? But like, say someone else, if they did that, you would start to think, oh, that's a little something, More of the short-term memory. If you start to see like more personality changes, being more paranoid, that can usually be a sign of some early changes.
I read an article and I can't recall the reference, but it stated something like if you start making doing typos when you're typing, you miss a letter that you normally don't ever miss.
Hello? Okay. Like I read that in on a Time magazine article, and it says if you start noticing these changes, and this could happen really, really early. It could even happen. I read something like even in the 30s. So if you start seeing these mistakes, I guess, that you never made before, it could be, but it takes almost it doesn't impede your job or what you do at home. It doesn't impede any of your activities that you do. But there are these things that you didn't do before. And
Right.
I'm wondering, are there exams or tests to detect that early on? And if it doesn't impede your activities of daily living, it doesn't impede life, do you even do anything about it?
So, the best historian for the diagnosis of dementia is actually the family and the people around the patient. Because when you come in to us, as Dr. Salazar will talk about later, we have a lot of different tests and assessments that we can do, but that's what we're doing in the office. That's not actually what we're seeing. So, I mean, a lot of times, like, who cares if you can remember 3 words? You know, if it's not going to affect your life, you can just keep notes, right? I mean, so we actually don't call it dementia until you have a decline in your functioning. Now, if you have something like you're mentioning where you're starting to notice that you're doing the typos, or there's something that you're starting to do a little more consistently than you did before, then yeah, maybe that's something to look at. You know, like maybe there's, you know, something going on. But if it just happens a couple of times, I wouldn't necessarily think that was, you know, like an early sign of dementia. Yeah.
If I may just add, it's really just losing the ability to retrace or step back. If you lose your keys, for example, we know that if you'll give up the search and go do something different, you know, something will trigger your memory and you go back and find the keys. But if you lose the ability to retrace those steps, that's when you should start paying attention and really go to your doctor to get properly diagnosed. Anyone else?
All right, well, it's 9, so...
You've got till 9:15 if
Oh,
need be.
9:15? Okay.
Yeah.
So we can talk a little bit about caregiving. So these were some of the expenses that some of the, what do you call it, costs from 2012 of how much we spent in only caregiving. So again, this is not the formal care, like broken hip, admission to hospital, infections, medications, all of that. This is only caregiving. So this actually ended up being about $214 billion in that alone. So as we said before, you know, these people need a lot of care. So more than 15 million Americans provide unpaid care for persons with Alzheimer's disease or another dementia. So that's like the daughter in our case, right? Who's going by 2 or 3 times a week to take care of their mom and dad. 2012, approximately 1.3 million caregivers provided billions of hours of unpaid care for a total cost of $18.2 billion. And what's included in that is the time off of work. You know, mom had to go to the hospital, dad had to go to the doctor. So, you know, teacher had to take off of work, or, you know, she was just too exhausted to go into work. Plus, you know, she had other, you know, things to do. They had to go pick up medications or, you know, something like that. So, let's see, just to give you an idea, in 2012, caregivers provided an estimated 17.5 billion hours of unpaid care, a contribution to the nation valued at over 216 billion again, which is approximately half of the net value of Walmart sales in 2011, and more than 8 times the total sales of McDonald's in 2011. So it's a lot of money going into taking care of these folks. So 65 million people, again looking at who are the caregivers, 65 million people, about 30% of the U.S. population provide care on an average of 20 hours per week. The majority of these people are also full-time employed, usually. About twice as much, $375 billion a year is spent on home care and nursing home services combined. So who's the typical caregiver? It's usually a middle-aged woman, well, usually not middle-aged, maybe between 30 and 50 years old. But she's full-time employed, has a family of her own, you know, children, either children or grandchildren, 18 and younger, living with her. And so she's got to take care of her parents and her children and go to work and all of that stuff. Plus, you know, when she gets sick, so.
I had a question earlier regarding diagnostics. What type of diagnostics do you run? I mean, I know lab work, but aside from the B12 and the folic acid, what other type of testing is done? And you do memory tests?
Yeah. So, like Dr. Salazar alluded to earlier, Alzheimer's dementia is a dementia of exclusion. So we look for different types of dementia initially. So our lab tests are looking at different electrolyte disturbances. We look at your thyroid. We look at anemia. We look at infectious causes, vitamin deficiencies. We look at infection that could just be causing delirium, which is kind of an intermittent confusion. We look at any structural causes, like if there are any brain tumors or any metastases of, you know, any cancers that may be going on. And so once we rule that out, then we can call it Alzheimer's disease. Okay. So as far as our cognitive testing, we do things called where we check your orientation, which is if you know where you are, who you are, the date, who people are around you. We do a short-term memory test, like a recall. We'll give you 3 words, see if you can remember those 3 words after we distract you after a few minutes. We check your ability to copy drawings. We check your ability to concentrate on either calculating or spelling words backwards. We have you draw a clock and then copy us draw a clock and see if you can follow the directions well. And then we check your physical, we do a physical exam. There are some dementias that have some physical findings that, you know, we can use for diagnosis as well. Does that answer your question?
Medications, interaction of other medications?
I didn't hear, I'm sorry.
Sometimes the medications also, the interactions?
Yeah, so that we look at too. So that would be part of like what we would call a delirium. That's kind of a temporary confusion. Because there are a lot of medications that can cause that. So we look at, you know, kind of the whole picture. We'll look at all your medication list, all your labs. We do imaging. And then also to see if there's any environmental changes. Sometimes people will become acutely confused when they get moved into a nursing home, or, you know, people painted their bedroom a different color, or somebody moved in the house, or somebody died, or, you know, different things like that. And elders can respond to that differently. So, also pain can be one of them. They can have an ulcer, you know, all kinds of things like that. So we look at all those things before you can call it dementia. So 51% of care recipients live in their own home, and 29% live with their family caregiver. About 4% live in nursing homes and assisted living. 36% of family caregivers care for a parent, and 7 out of 10 caregivers are caring for loved ones over 50 years old. And like I said, primarily those are kind of the women caught in the middle, I like to call them. So what about the caregivers? So these women are actually 2.5 times higher to live in poverty and 5 times more likely to receive SSI. Caregiving families have median incomes that are more than 15% lower than non-caregiving families. And then during the 2009 economic downturn, about 1 in 5 of these family caregivers had to move into the same home with their loved ones to cut expenses. And a lot of times they never move back out. So they're still kind of taking care of them if they haven't passed away. So 47% of these working caregivers indicate that they've used all or most of their savings. An average family caregiver for someone 50 years or older spends about over $5,000 per year. And these were based on caregiving expenses in 2007, which is more than 10% of the median income for a family caregiver that year. So we spend a lot of money out of pocket, at the very least. So again, most of our family caregivers are employed full-time, which travels over to our American businesses. So they can lose as much as $34 billion each year due to employees needing to care for a loved one. Like I said, the time off to take them to the doctor, or if they need to go to the hospital, or pick up medications if they do become ill, something like that. Caregivers caring for elderly loved ones cost employers 8% more in healthcare costs, estimated to be worth $13.4 billion per year. So what about Medicare? Let's switch over to there. Okay. So long-term care in a nursing home, Medicare may pay for up to 100 days of care in a skilled nursing facility. Will cover 100% for the first 20 days. For 21 to 100 days, the beneficiary pays the daily co-insurance amount. I forget. Does anybody know exactly what that amount is? It's based on income, is that right? Okay. And then assisted living costs, generally not covered by Medicare. And a lot of people require assisted living well before they need like the full nursing here, right? So to try to get these people into just a place where they can get some home provider assistance is difficult, because home provider assistance can be expensive as well. So medication-wise, this is kind of a busy slide too. These are most of the medications that we use to treat Alzheimer's disease. So Aricept, Exelon, Namenda, and you can see the ones in red are not covered by that particular Medicare plan, which I think is a lot. Sometimes people cannot cover or cannot tolerate those other medications. The QL indicates that the plan limits the number of pills that that person can receive over a period of time. So changing the dose gets very difficult for some of these people. So in the end, in speaking about disparities, so individualistically, you have language, migration, mistrust, literacy, transportation, and documentation that you need to be aware of as far as your patients go. And then as an organization, keeping track of the complexity of your patient and where they're coming from and how we're interacting with them, tracking the application of your knowledge, skills, and being able to adapt to that. Training staff members to be able to elicit that information, treat your patient appropriately and individually, funding for that. Having a bilingual staff is helpful. And then systems-wise, geographically knowing South Texas and kind of where geographically we're treating our patients and knowing that population. The uncertainty of where the population is moving to, since this area, I guess, is growing so much. And then reimbursement, particularly with, the Medicare system and getting them funding and home care providing and medication and things like that with the Medicare system. That's it. Other questions?
Thank you.
The raindrops are falling, they pitch on their heads. Their uniforms are heavy and wet.